Next, up until lunch, is going to be kind of focused on glaucoma. Kind of primary conversation around this is the challenge of sustained IOP control. And so we'll go into kind of what our current treatment model looks like, including drops, MIGS, kind of go through some pros and cons with that. And then kind of focus a little bit on some of the newer implants that have sustained release medications, and kind of go through the history and talk a little bit about how we would use those or how we talk to our patients with those.
Did you come up with that slide on your own, or did Maddie help you?
This slide?
No, the other one.
How do I go back?
The bottom one.
Never mind.
You're going forward.
Good job, Maddie.
Maddie had 0. This slide?
Just keep going.
Sorry. This one?
Oh, the next one, that one.
I will say that versions of ChatGPT are very beneficial, specifically in kind of going through pictures and highlighting points. So I had to make a lot of edits, but still. All right, so current glaucoma treatment landscape. Obviously, we have go-to medications. They're effective, they're easy, they're simple, but obviously challenges in regards to adherence, side effects, patients kind of understanding the necessity and how to use them. We have SLT, we've talked about a number of these in other symposium. MIGS options, and then we have traditional surgeries with trabeculectomies, tube shunts for more advanced glaucoma. Again, big things that we kind of focus on in this conversation is patient adherence, ocular surface disease, side effects, make it to where patients don't like to take their drops. It's not for every patient. Obviously, some patients do great on drops, but in those missed doses, and potentially as we get into a little bit more, certain medications, they're once a day, but everybody kind of flushes them at different rates, and so they're not necessarily 24-hour control. And so fluctuations in IOP, in seeing those patients that measure a good pressure, but yet you kind of slowly over the course of a year or 2 or 3 see progression of field or progression of RNFL thinning. So the drop alibi, pros of drops, again, this is the least invasive option as far as how patients consider them. They're simple, they're reversible in the sense that if the drop doesn't work, you just stop taking it. If the drop causes too much pain or irritation, or they have too much of a reaction, hypersensitivity to it, you can discontinue it. They're generally well tolerated, and typically side effects are very localized. Hyperemia, dryness, very rare to get any type of systemic side effect. As opposed to talking about the S word and mentioning surgery, it's a scary thing for patients. I think one of the biggest things, downsides when we talk about MIGS, is you have to talk about a procedure. You have to typically talk about an incision, and patients have fear over that. No different than when we talk about cataract surgery. A little bit less with LASIK because they're pretty motivated to have that taken care of. Again, they're convenient. These are accessible. Many of the drops, very, very affordable. They're in generic forms at this point. Obviously, some of the newer medications, the rho kinase inhibitors, Vyzulta, those types of things, can carry a pretty hefty price tag, but typically fairly easy and accessible for patients to use. Surgery requires more of an upfront cost. Depending on copays, deductibles, it can seem like a bigger step, a bigger leap. It requires scheduling rides. It just requires a little bit of additional baggage. As far as talking about kind of the downside to drops, obviously I think we focused on compliance in other discussions. Nick, you have a patient that comes in and just kind of tells you, like, you know what, I take my drops when I remember, but I probably get them in 60% of the time. They have mild glaucoma, they're on one medication. When you measure them, they're good because they take their drop the night before, and so you get a pressure of 15 every time. What's your conversation look like with this patient?
I remind patients that when we check eye pressure in the clinic, it's like it takes 3 seconds, and so I know what their eye pressure is in that moment at that time, but for the remainder 24 hours of the day, I have no idea where that pressure is at. We know eye pressure is usually higher when we lay flat and sleep at night, so I don't know what their eye pressure is in the middle of the night, but they've studied that, and we know it goes higher. So their eye pressure in the clinic is just one moment in time. And then that gives you a really good paragraph you can type in their chart about, patient has failed, non-compliant with topicals, and then the door is open for them as far as what we can do next. But I'd talk about laser, I'd talk about MIGS at that time.
Yeah. I think obviously depending on severity of glaucoma, you can be a little more friendly in that conversation. Obviously patients that have more severe glaucoma, I had a patient in the office 2 days ago, yesterday, who's NLP in one eye and moderate glaucoma in the other eye, still just not a good patient, and had a very blunt conversation to say, like, you will go blind. Like, this is gonna happen, it's a matter of time. He's 20, 25 in his good eye still. He understands it and ended up coming across a little harsh. There were some tears and then a phone call afterwards with a little bit of an apology to say, like, I didn't mean to come across hard, but these are patients that you can save their vision, but if they don't listen, if they don't understand the disease, or if they're just non-compliant, you need to find alternative options. There's been studies that have shown non-adherence rates between 40 up to 80+% using these medication event monitoring systems. So basically these devices on the drops that will actually record when they're used, how they're used, compared to kind of self-reported non-adherence being 0 to 30%. Just a quick show of hands for our ODs up here. A patient comes in and tells you that they take their drops 100% of the time. Do you believe them? Anybody?
No.
Depends on the patient.
Okay. 100% of the time.
They're a male.
What?
They're a male.
No.
Yeah. I think it's anytime somebody says I never miss, I just cannot imagine it. Like, life is life. I'm a terrible patient. I tell every one of my patients, like, I'm a bad patient. I do not take my meds as I should. I miss doses. Like, this is part of our life. But I would rather have them tell me up front so that we can determine where they're at.
Yeah, I think it's important the patient is honest with you, because if they are taking their medications as they're supposed to and they're still progressing, then we need to change the plan.
Yeah. Again,
Follow-up question. What percentage of patients do you make cry?
it's low percentage-wise. I see a lot of patients, so it's probably less than 5%.
Okay.
A good reminder, there was a really good doctor named Dr. House, and he has a quote that all patients lie, and that's the truth.
House knows. Moving forward, ocular surface disease, redness. Again, not every patient experiences these. I had a patient within the last couple of months who was sent in unilateral glaucoma. I can't remember if there was a trauma related to it or whatever it was, but had been using Travoprost or some PGA for the last 5 years and had the reddest right eye, and her left eye looked perfectly normal, and was in talking about alternative options, was fairly well controlled, but really was just so irritated at the kind of aesthetic appearance of her eyes that Lumify wasn't cutting it. She was dosing it 2 or 3 plus times a day. And so this can have an impact. And the longer you're on these medications, the more prominent it becomes and the more permanent it becomes in my decision. Even patients that I've seen come in and we've done cataract surgeries with MIGS, oftentimes they don't get the benefit you'd think, a recovery of kind of that white eye that they'd like once they're discontinuing meds. Washout effect, again, missed doses cause fluctuations in IOP, and it's been shown fluctuations in IOP can cause progression of glaucoma as well. Last thing, as far as the drops goes, pharmacology, it's estimated that probably no more than 5%, likely less than 5% of the medication reaches its target through an eye drop. Blinking, nasolacrimal drainage, absorption through the conj, these are things that basically just cause a good majority of that drop to not reach its target, to where we know, yes, they can be effective. The question is, I think on an individual basis, how does that bioavailability differ patient to patient? So as we jump into MIGS and kind of talk about, kind of swing this to more of a positive conversation as opposed to just surgery, these have the potential to reduce reliance on drops. Again, I tell every patient, we don't promise elimination of drops. You may still need drops. But specifically for patients that maybe just have a difficult time remembering their drops, and we know there's fluctuations, we've seen progression, this is an option that can kind of lower that ceiling to where when they miss a dose, if they still need a drop, it's less likely to go as high and we're less likely to see progression. You get consistent pressure control. Again, medications have a wash, it will basically see that pressure spike back out once you see hours pass after the drop goes in. And so benefits here, basically looking at trying to find out how do we improve our glaucoma control, reduce potential for progression, when we know patients overall do pretty well with drops, but we also know they miss. And so we know that, the kind of standard MIGs we've talked about, we do as many of these as we need, but oftentimes tandemed with cataract surgery. We wait till cataract surgery, oftentimes potentially even waiting too long, waiting for cataracts to develop so that we can do kind of an all-in-one treatment. Russell, what are your thoughts as far as, obviously we know that for where things are at right now, iStent, inject, canaloplasty, these things, there's a few of them that can be done on phakic patients or already pseudophakic patients. What are your thoughts as far as addressing these, or when to address them with patients?
Yeah, I think, there's kind of two clear things. One, if somebody has concurrent cataract and they have glaucoma, 100 times out of 100, that patient should have a minimally invasive glaucoma surgery with whatever surgery, with their cataract surgery. And I think that I tell patients that's a pretty hard non-negotiable. This is the best thing for your eye. We have years and now decades of data supporting MIGS has an equivalent safety profile. If you're doing cataract plus a stent versus just a cataract, they have equivalent safety profile, and so that's a really important thing. The standalone patients that are phakic or pseudophakic, traditionally we didn't have as many options. Now we have both canaloplasty and stenting options for those patients. And so I think it's just important to know if you have a young phakic patient or you have a older pseudophakic patient who has mild to moderate glaucoma, we do still have some minimally invasive glaucoma surgery options for them. And so if topical drops are problematic, or more hopefully, if they've had a SLT treatment, but they're a non-responder to SLT, to know that there are still some other options besides, daily drop therapy for those patients is an important thing to know.
So as far as kind of looking at a few newer options, one just recently in the last year, and then one about 4 or 5 years ago, I believe, these implantable devices that have sustained release medications with an intention to reduce fluctuations in IRP, reduce the potential of progression. First one being Durysta. This is a biodegradable implant. It has a small amount, 10 micrograms of imatoprost. And basically this is, for lack of a better term, injected into the cornea. It settles into the lower inferior angle and continuously kind of biodegrades, releasing its medication 24/7. Initially designed and kind of studied for a few months, but also seen potentially last, depending on breakdown and kind of individually, seen up to 2 years. Was that me? I personally haven't had a lot of experience with Durysta. Anybody up here want to speak a little bit to it?
Yeah, we use Durysta in Fargo often. I've had the most success combining Durysta with SLT, doing SLT first, and then Durysta a week or two later. SLT and Durysta probably have, because we still don't understand fully how SLT works. We know that it works, but I think SLT and Durysta probably have a very similar mechanism of action, as they're both stimulating inflammation, and Durysta being a PGA is a pro-inflammatory drug. And what's awesome is I think we as providers forget how awesome the corneal epithelium is at keeping stuff out of the eye. I think the corneal epithelium is one of the strongest or smartest tissues of the eye, but the epithelium is very hydrophobic and the corneal stroma is very hydrophilic, and so to put the drug in the eye next to the target tissue makes a whole lot of sense to me. And the reason that the amount of drug in that implant, whether it be Durysta or iDose, can be so small is because, we forget when you put a drop on the eye, I would argue that less than 5% actually penetrates the cornea, gets into the anterior chamber. So We've used this in Fargo. Depends on the patient, depends on how long, we're looking. In the FDA clinical trial with Teresa, they re-implanted every 3 months. But I've had a ton of success with combining it with SLT.
I think, yeah, to your point, when we talk about bioavailability, that's why I think there's such an abrasiveness to glaucoma meds. Like, I would almost use the term toxic because they're so heavy-handed in the amount of medication that's there to try to penetrate into the cornea, or the carrier molecules that are designed to kind of penetrate the cornea, which is why they're so upsetting to the surface. This one just recently approved, the iDose TR. This is a titanium-based implant that has quite a bit more, 75 micrograms of Travoprost. This is anchored into the trabecular meshwork. Same thing, delivers a 24/7 medication that, again, by design and trial, lasts up to a year. Based on what we've seen, based on our involvement in one of the studies, I believe Fargo's doing another study on this currently. We've seen effect up to 3 years.
Yeah, obviously when you put the iDose in, we were involved in the initial study with iDose, and now we're involved in combining iDose with cataract surgery. Obviously when you put the device in, the level of the drug is going to go down with time. And so the efficacy of the IOP lowering effect does go down with time. But in our study, they were able to prove 3 years of IOP control. But the initial IOP lowering effect you get with it on, week 1, month 1, the drug does dilute over time, and then you lose the drug eventually. And I believe what other clinics is now looking at an exchange study is what happens after 3 years. Well, you can safely swap them out.
We'll kind of jump through a quick history here. Kind of early 2000s, kind of concepts for sustained medication delivery was basically evolved in ophthalmology based on kind of poor control or patient adherence as far as drops go. This is not the first of its kind. Obviously, sustained release medications have been used. Punctal plugs, we were part of a study that used Dextenza, which was a dexamethasone releasing punctal plug in conjunction with cataract surgery. Ozurdex obviously has been used intravitreally. And so again, this is something I think will continue to be ongoing, really with an intention to do our best to take control of glaucoma or these types of things out of the patient's hands. Again, I think one of the hurdles with glaucoma is many patients don't understand it. It's, no pun intended, it's kind of a blind disease. They don't feel it, they don't sense it, they don't feel a pressure. Most obviously early mild to moderate glaucoma patients don't really even notice a change in vision. And you're kind of telling them, well, we need to treat this. This could cause blindness, and without proper patient education or an understanding of, or them potentially having a family member that went blind from it and kind of knowing at that point, it just reduces the potential of them being adherent. 2010s, glaucoma started research, R&D on this Travoprost delivery. Into the teens, they went through a couple of the phase 2 and phase 3 trials. This is where, for effectively going through the FDA process, verifying that there was safety and efficacy, found that there was great safety profile, sustained IOP control, and then Durista is approved in 2020. Again, primarily or only approved for primary open-angle glaucoma or ocular hypertension. And then this last year, iDose receives approval. Same thing, same label, POAG and ocular hypertension. So we just kind of walk through labeling. Both are, I think the really nice thing for these is that there is the ocular hypertension label here. It's rough to sit here and wait and see a patient have ocular hypertension, treat it, not actually have true glaucomatous damage, and know that really our only option is starting them on drops. And again, many of these patients are younger, potentially late 40s, early 50s, and you know that without access to these types of things, they may on drops 30, 40 plus years. Again, prostaglandin analogs target the trabecular meshwork and uveoscleral pathways to increase aqueous outflow. I'll pass this over to Sierra, glaucoma queen. We talk about kind of who's a target suspect, which type of patient do you look at? Let's specifically talk about iDose. who do you look for in a patient, or maybe what their history looks like, how they've used drops? When do you start to have this conversation?
And there's really only like one specific target, so I hope you nail it. If you don't, I'll let you know what the answer is.
What?
There's one specific target. There's one
Target suspect.
target
Got it.
suspect.
No, there's many. We recommend and use iDose in a pretty wide range of patients. If they're having cataract surgery and they have glaucoma, mild, moderate, or severe, we would talk with the patient about it and recommend it. And the only thing would maybe be like a known prostaglandin allergy where we would avoid that. But for most patients that fall in that fall into any of those categories, we would recommend it, especially if they're having cataract surgery. If they're not having cataract surgery, I think still reasonable. If a patient's just on latanoprost and doing well with it, then probably doing surgery isn't necessary unless they're needing additional, they need a MIGS procedure with it or something like that. It can be combined with MIGS procedures. So it's a nice add-on nice add-on in a lot of cases.
Partially correct. The target suspect is Medicare supplement, and you can do it.
Thank you.
For now.
Thank you.
You're welcome.
Insurance.
Not glaucoma suspect, however.
POAG or ocular hypertension.
Insurance is still a hurdle, being that it's newer, specifically for iDose. Coverage is getting better. I think it's improved even in probably the last 3 months. But insurance is still a hurdle for these patients where we feel like they were great candidates for it. Payment of it is still a challenge at this point. So, again, this removes patient adherence, right? We're attempting, or reduces patient adherence, attempting to lower IOP. I tell these patients, you still may need timolol twice a day. You may need timolol once a day. The hope is that we're kind of lowering the ceiling, getting pressures to where when you miss a dose, that spike doesn't go as high, and reducing the potential of progression of field or RNFL. Again, reducing ocular surface exposure, not having to place a prostaglandin or other drops on the surface. I know patients that have just flat out told me like, well, the drop stings, so I only use it 3 or 4 times a week. Or if I know I have to go, I'm going to a meeting in the morning, like I won't use my drops in the morning, my COSOPT in the morning, whatever it may be. And so again, not necessarily fully understanding the impact that carries. I think, true benefits of these options outside of the patient adherence component is reducing side effects, which I think most patients learn to tolerate. We all live in Montana, we tolerate a level of dryness here, but you add glaucoma drops to it, and it definitely makes it significantly worse. So as Sierra kind of alluded to, this can be tandemed, specifically iDose can be tandemed with cataract surgery. As we know, we've shown, we'll kind of jump into a few things. We've shown eye stents combined with cataract surgery, the benefits of IOP lowering components. Again, this is still patient to patient. We still tell these patients, depending on their starting pressure, depending on how many medications they're on, that they still may require drops, or that this, we may get great control, they're off of medications, but over the course of the next 3-5+ years, that there's still likely continued degradation occurring at the trabecular meshwork, and their pressure can creep back up and potentially need to go back onto drops. Again, the higher the starting pressure, the more impact. We've kind of seen that with latanoprost, with SLT. Same thing goes as far as talking about iDose, just as far as how it functions.
Can I just mention one thing on that? I think, like historically, this is one, if we go back one slide, where glaucoma specialists have had a pretty big hesitancy. If a patient walked in with a pressure of 30 or 35 or even 40, there was a historical thought that even if they're mild or moderate, that patient needs a trabeculectomy or a tube shunt. And I think what's important to know, again, the higher the baseline IOP, the greater response you get with a MIGS-based procedure, just like drops, just like SLT. So even a patient, mild, moderate, or even severe disease that has a high elevated intraocular pressure, that historically might have said, hey, that has to go right to a trab or a tube, that has pretty significant ocular side effects and risk profile for hypotony or scarring or otherwise, tube erosions or other things, we will almost always try a MIGS-based approach first for those patients with the conversation of, hey, we're gonna see where this settles out. We'll have a good idea in the next week and certainly by a month what effect you're gonna get from this. if you're on multiple meds, you're still maybe going to still have to be on 1 or 2 medications. But the risk profile of a combined MIGS procedure, canaloplasty or stent plus an iDose is infinitely different than the risk profile associated with a trabeculectomy or a tube shunt or a Zen subconjunctival stent. And by doing a MIGS-based approach first, we still preserve that option down the road for them. So this is something I feel very passionate about, that hey, we really want to preserve these patients from having a big incisional glaucoma surgery if we can. And again, when we've looked at our even just subset of severe patients, about 70% of patients, we have a published study where 70% of our patients in the severe category, we were able to avoid an incisional surgery by doing a MIGS-based approach. So I think it's a super, super important fact to keep in mind.
And I love stents, and I'm pretty stent heavy in Fargo because, you do a stent or stents, you can still do SLT, you can still do a canaloplasty, you can still do a tube or trap, hopefully not, cook dual blade. I mean, kind of like ICL preserves real estate in the cornea, like stents preserve the angle for anything else that patient may need down the road.
And I think, Russell touched on it as well earlier. Talking about surgery as a standalone, talking about surgery with patients, nobody wants to have that conversation if it can be avoided. Obviously, when we're talking about cataracts, they've already had impact to their vision. You've seen them, you've told them, glasses aren't going to cut it anymore, you need to go have surgery. This is where it's, to Russell's point, we're intentional about it, but it's also a very easy conversation to say, we're already going in to correct your cataracts, let's do what we can or look at our options to try to reduce pressure. And every patient I see just nods their head why wouldn't we do that? I think the difficult part when we talk about standalone procedures is, again, there's an alternative, there's drops, right? And depending on how that conversation's phrased, it can definitely swing the patient one way or the other, no different than SLT. Dr. Dede, what are your thoughts on, if you're talking about whether, let's say it's SLT or iDose as a standalone, how do you phrase that conversation as opposed to, when you're giving a patient options, drops versus SLT versus iDose, how do you put the patient at ease?
I'll be honest with you, I'm not having those conversations too often because I don't see the glaucoma patients as much. But I think it really goes back to the history of how well have they been doing with the drops. How old are they? Are we looking at drops for 30, 40, 50 years? Then I think if they're a good candidate for SLT, I talk to them about it, and if they're comfortable with it, I would plan to proceed. Do we do much for iDose? Just straight? Yeah. Standalone?
You certainly can do it, but again, insurance-based or otherwise, it's, to Travis's point, we're probably most often 80-90% of the time implanting it in combination, but it can be done standalone, and the FDA trial was done standalone.
Okay, I just haven't had too many of those, but.
Let's talk about drops versus SLT a little bit more because...
Nope, I can't let you do that because I'm going to talk about it later today.
Okay, fine.
And this isn't your talk, this is Travis's.
I'm just up here to disrupt.
I think as far as that conversation goes, again, surgery sounds invasive. It sounds rough, right? Talking about iStent inject that we've done, or iStent infinite, so it can be done as a standalone. I tell patients this is a 60-second procedure. Yes, we're making an incision, so just like with PRK, just like with LASIK, there's risk for infection. We put them on antibiotics, minimal to no impact on vision. Patients that have been in a part of our study, I tell every patient, you might have a little bit of fuzzy vision for a day or two, but typically they come back the next day and I didn't even know what happened. Same thing as far as what I would expect with iDose. We've had a few patients that we've done iDose as a standalone. Had one that we did in conjunction with canaloplasty, I believe, for more poorly controlled IOP in a patient who just flat out said, I'm not going to use my drops. And so that was an easier conversation. He knew he had one option. But I think, again, putting a patient at ease, talking about yes, there's a surgical component, there's a procedural component, you'll need a driver, but recovery's quick. There's no downtime. Because of the incision, there's a limitation with dirty water, swimming pools, hot tubs, that type of stuff. But outside of that, you're back to your normal day. I would say within 24 hours, you might have a little mild amount of blur, but pretty tolerable.
You maybe are going to touch on this later too, but I would just add that, most patients that come in for a cataract eval that also have glaucoma, most of the time you've already talked to them about a MIGS procedure when you've sent them in. And the coverage for MIGS procedures is constantly changing, and it's hard for us to keep up with them. So we certainly wouldn't expect, like, tell your patient exactly what MIGS procedure they're having, but it changes a lot. And so, you know, the generic kind of umbrella term of, like, you're going to probably be offered a MIGS procedure is sufficient, and then we can kind of get into the details of what MIGS procedure, and most of it is honestly based off of, like, what's covered, and it's changing often.
We had a redundant slide there. Again, as kind of briefly discussed, iDose can be tandem with other MIGS. So tandem with iStent inject. I think we've had iStent Infinite. We've had a patient we've done that with, tandem with omnicanaloplasty. Again, all depending on control. If patients are on 2 or 3 medications and there's still poor control, going into the eye and doing one thing, again, it's similar to cataract surgery. Like, we're already there. If it's covered from a medical insurance standpoint, then it's worth the conversation of what else can we do with an extra 60 to 90 seconds to further lower IOP. Again, still stressing that some of these patients, depending on their severity level and where their IOP is at, still may require drops. I don't know what happened to my slides here. They look a little funky.
Can I just mention one thing on the post-operative part for
Yeah.
iDose as well? So again, particularly if you see a patient that's, you know, the most common that you'll see this coming back to your office is probably in combination with cataract surgery plus a stent plus an iDose. Again, if it's an ocular hypertension patient, it might just be cataract surgery plus an iDose. If they want to do it standalone, just as an iDose. But what we're telling patients, again, we're effectively replacing their prostaglandin therapy, which most are on as a first-line treatment. So day of surgery, they immediately stop their prostaglandin because we've taken their topical prostaglandin and now put it in their eye. And then usually if they're on other medications, Timolol, Combigan, Cosop, whatever it might be, we'll usually say, similar to what we said before with other MIGS-based procedures, stay on your other glaucoma drops, watch as you go through the next week and month, and ourselves or your primary doctor back home will kind of tell you, based on how your pressure is, we'll adjust those drops from there. But important to know, we tell them, again, immediately okay to stop the prostaglandin. And honestly, it's like wildly amazing. If you think about how big like a bottle of drops is for a month, the implant is 0.5 millimeter by 1 millimeter in size and holds up to 3 years worth of medications in them. And they've done really cool studies in Armenia where they've explanted them every 3 months and both tested the aqueous to make sure that there's still an adequate concentration. Yes, there is. And then that there's still medicine in the device. And yes, there is. And so it's a really, really incredible device. If you're looking at it, you know, an iStent, oftentimes you won't be able to see without gonioscopy. This device, it's anchored to in the same spot, but extends 1 millimeter into the anterior chamber. So you'll typically be able to see it without gonioscopy. Although interestingly, most patients won't see it. It's usually kind of superior nasal is where we try to orient it. So it's kind of hidden up under the upper eyelid, not always. As the FDA trial, 2/3 of patients got it, 1/3 of them didn't. They were masked to it, and we didn't have any patients who had or didn't have it who identified with absolute certainty that they did have it, which is pretty amazing because it's very easy to see at the slit lamp, but for them to actually optically see it is very unusual.
We had one very nearsighted patient who made a good, educated guess that she had it. Yeah. So as far as, again, talking about its combination, it's a type of MIG, but this is, again, pharmaceutical in nature. This is releasing medication inside of the eye. Nick touched on it a little bit. Again, there's a limitation to how long this is going to last. And for some patients, it might be a year to 18 months. For some patients, you get 3+ years. So the next kind of question comes up of, well, what then, right? We know this isn't a cure-all. We don't really necessarily have a cure-all for glaucoma. There's always potentially something coming up depending on how advanced their glaucoma is or how progressive it is. Russell, do you want to touch on as far as kind of what we've talked about with patients or what's been considered there? I've had patients ask, like, do you just refill it? Do you take it out, put another one in? What happens after 3 or 4 years?
Yeah, so after it loses effect, currently it's FDA labeled. It doesn't mean that's the only way it can be done, but it's FDA labeled as a one-time use. But the FDA trial, there was an arm of patients that were enrolled in a exchange program. So once we're at the 3-year mark, the iDose, you go in, you actually just grab onto it, you remove it, you put a new one in right beside it. And those studies, those patients didn't show any decrease in endothelial cell count. they did very well. So the anticipation is that we'll eventually have a code and an approval to be able to do this as a repeat procedure. There's also in development what will probably hopefully be like a 5 to 6 year sustained release device in a similar matter, and that'll probably go into FDA trials this coming fourth quarter or maybe first quarter of next year. So what I've been telling patients is, again, we anticipate you'll get 2 to 3 years of effect from this based on the FDA clinical data that's available. You need to continue to have your glaucoma monitored. It can still be progressive, or this could lose effect. When that time comes, we would anticipate that we could just go in and exchange it for a new one at that point.
We're going to jump along here a little bit. Looking at some of the stats as far as what was collected with some of these trials, obviously kind of end result or endpoints, we're looking at control of IOP and consistency of control of IOP and how long it lasted, but also looked at how many of those patients were able to get off a drop or more. 81% of the subjects who received the iDose were completely free of IOP drops. 23% of those patients had 2+ medications. Again, it kind of tells you, I would tell patients, if you're on 2 drops, we'll probably get you off of 1. There's a potential we could get you off of 2. Again, that concentrated dose that's directly delivered to the target tissue has a bigger impact than what you're carrying with, the drop bottle in your pocket. And again, then directly compared the intracameral PGA compared to topical PGA, found approximately 1.3 millimeters lower pressure with intracameral. Again, that washout effect, that loss of medication to tears and blinking and nasolacrimal system and conjunctival absorption plays a role there.
And I think this is such an important thing, because sometimes, again, on the, hey, I have a pseudophakic patient who's on a drop, and it's irritating them a little, or I'm worried about compliance. They're worried about safety. Demonstratably in the clinical trial, the intracameral delivery of prostaglandin was more effective than those patients who were on a topical prostaglandin before. The rule of thumb from some of our other glaucoma studies, a 1 millimeter drop in mercury is about a 10% reduction in glaucoma progression. So I feel like very definitively you can tell patients, hey, this is more effective than a topical drop, and you're 100% compliant while it's in there and working. Now, again, if a patient, they may still want to choose for a drop, but if they're kind of questioning the efficacy of it or otherwise, it is demonstratably absolutely as efficacious, but the data actually shows it's more efficacious than a topical drop, which is an important fact to know, I think, as you're talking to patients.
81% of patients drop-free is pretty awesome. And I think it's important when we talk about any MIGS device, we have to be careful how we measure success, because it's not uncommon we have that glaucoma cataract eval, patients got mild glaucoma, and they're on latanoprost and timolol and their eye pressure is 15. And it's like, guess what? We're not going to get your IOP lower than 15 with stents. It's hard to get anybody's eye pressure lower than 15, and we probably don't need it lower than 15. So when we talk about IOP lowering with patients, or we're going to try to lower your eye pressure, they're like, okay, sounds cool. And it's like, in a perfect world, maybe get you off both or probably one of your drops. They're like, oh, that'd be amazing, because the drops are the most burdensome thing for them in that moment. So you can, measure success with MIGS 2 ways, not always IOP lowering, but getting them off these drops.
Safety profile, no clinical significant endocell loss, so no DSECs, no DMECs, no serious adverse events within the study. Again, obviously, it is a medication. There's potential for hypersensitivity, no different than with a drop. There are some risks and side effects we talk about, and then kind of go into contraindications based on that. We know prostaglandin analogs have this kind of potential for kind of a pro-inflammatory component, so has a potential to induce macular edema, no different than the topical does. Increase in intraocular inflammation, iris pigmentation. I have a patient that has had progression of glaucoma. She's been delaying cataracts, 2025, mostly just very fear-based around eye surgery. But she's kind of transitioned from mild to moderate glaucoma. She has 2 to 3 plus NS and just tolerates it, glares to probably 2400. And so for the last 3 visits, we've been talking prepping, you need to have something done. Obviously, we need better control of your IOP, but you've got cataracts as well. It just makes sense to move forward with cataract surgery and combine it with stents. And her biggest fear is, and she's on latanoprost at night, she's on Cosopt 3 times a day, and I believe she's on bromonidine twice a day as well. And her biggest fear is, well, is it gonna discolor my iris? And I kind of tell her, like, you're already on this medication, like it's the same thing, it's just inside of the eye. I don't know if there's been any studies done to show because it's inside of the eye, because it's it's right in the aqueous, does it have a higher potential for iris pigmentation or depigmentation?
There haven't been any documented case of iris depigmentation with iDose yet. But that's usually seen with long-term prostaglandin topical therapy, so we'll see. But in the FDA clinical trial, there was no iris depigmentation or color changes in the study population.
Again, incisional, just like anything, the potential for endophthalmitis, very, very low. I tell patients, just be a good patient, follow the instructions. Risk is never zero for anything, but very unlikely. It is titanium-based, MRI conditional. I just got a text, didn't see who it was from, about how does this pertain to MRIs. I don't know a lot about MRIs. I did actually reach out to an X-ray technician that's in the building with us now. He kind of looked at it and was like, I don't do MRIs either, I don't know. 3T or less, from what I looked at, sounds like basically you can get that your doctor needs to be aware of it, the patient's doctor needs to be aware of it, but 3T or less typically tends to probably qualify 90+% of MRIs, that it's similar to an eye stent, to where very minimal reaction. Russell, any?
Yeah, to my knowledge, there's not a greater than 3 Tesla MRI in Montana. The place where you historically would commonly see it was a research-based institution that would have like a 4T or 6T MRI that they were using for research purposes. But for common medical MRIs that are done, to my knowledge, there's not one in Montana.
Brooke says, as she's helping us out from afar, it's on Glaukos' website, acceptable for MRI. Again, there's limitations with anything, but I don't think it's very... I'm sorry, say that again? There's like a big table that describes all the MRI, Gotcha. So basically it'll show you when you shouldn't have it or what, what's probably beyond a 3 Tesla. Thank you. So again, based on some of those risk side effects, there are some contraindications. Patients that have suspected or active infections, any presence of any corneal disease, prior transplants that have a potential to maybe disrupt, narrow angles where you don't have access to the angle to anchor the iDose. Patients with history of recurrent uveitis or iritis, same with kind of chronic or recurrent CME, no different than being intentional about kind of keeping these patients off of latanoprost or PGAs from a topical treatment. As far as kind of where we're at, I think it seems like every 2 or 3 years something new comes out, or we're part of a study that just gives us one more thing to look at, right? Over the course of probably the last 15 plus years, I stents 2012, is that right, for first generations? We're on 3rd generation now. I think it's not a save-all, but I definitely see it, both iDose and Durista, now maybe looking at potentially using Durista in combination with SLT, as Nick has kind of stated that, very impactful there. But I think it gives us, kind of one more tool, not needed for every single patient, but there are definitely likely patients that you have in your chair that are either poorly adherent or having reactions, maybe less controlled. You have them on numerous medications, where these can provide us with alternative options for better control. And I think that's it.